HARMONi-2 data were finally published in the Lancet, and this is, I think, a pretty important trial. History will tell us whether this was really the mark of a new era or not. This was a randomized phase 3 trial, fairly large study with almost 400 patients with advanced non-small cell lung cancer, PD-L1 positive, who were randomized to receive standard pembrolizumab or ivonescimab. Ivonescimab is a bispecific antibody that targets PD1 and VEGF, and importantly, features cooperative binding, meaning this agent may be greater than the sum of its parts, more than just blocking PD1 and VEGF. Really, by constructing these in a bispecific, when it engages one molecule, it's more likely to bind to the other, making it potentially a more powerful agent. And this study looked at ivonescimab versus our standard pembrolizumab. Now, some might argue pembrolizumab not really our preferred treatment for PD-L1 low non-small cell lung cancer. I would agree with that. But based on Keynote-042, it is an approved option. This did allow PD-L1 low or PD-L1 high. Now, overall, in the general population, what we saw was ivonescimab was significantly better in terms of progression-free survival, doubling the PFS from 5.8 months to 11.1 months. That's a hazard ratio of 0.51. Now, if we look specifically at PD-L1 high, where pembrolizumab is a clear standard of care, the hazard ratio holds up at 0.46. In PD-L1 low, hazard ratio 0.54. We saw the benefit of ivonescimab superior really in every meaningful subgroup, including squamous with a hazard ratio of 0.48 and non-squamous hazard ratio 0.54. Higher response rates, 50% versus 38.5%, higher disease control rates. There is more toxicity with the newer agent because we are engaging VEGF. We do see some VEGF-related toxicities, such as hypertension, proteinuria, but really not a significant difference in terms of arterial thromboses. And if you look at the grade 3 immune-related adverse events, pretty similar between the two arms, 7-8% for both. We have a couple unanswered questions, though. These data are, I think, profoundly impressive. A clear improvement in progression-free survival, which begs the question, should ivonescimab really replace pembrolizumab across the board? Now, we have to show that with different studies and data, but I think first the question is, does this data really apply to sort of a global population? This study done only in China, and so one question, does this apply to a Western population with Western regulatory oversight? Can these data be replicated? But also, just as importantly, will this translate to an improvement in survival? On a study like this, OS is event-driven, so we don't have OS yet. Median follow-up was less than 9 months, so we don't know about OS yet. And if this is a transient improvement in PFS with no OS impact, which we've seen with VEGF before in different settings, then I think it'll be much less impactful. But if this translates to an overall survival benefit, one could certainly foresee a future where ivonescimab or other bispecifics replace pembrolizumab or other PD-1 or PD-L1 inhibitors. Still have to do the studies, and so we'll expect to see results from HARMONi-3, which looks at ivonescimab with chemotherapy versus pembro chemo, and HARMONi-7, which is replicating those results, ivonescimab versus pembrolizumab and PD-L1 high lung cancer in a Western population. Those studies ongoing, others planned. Where will ivonescimab fit in terms of our treatment algorithms for the general PD-L1 high, PD-L1 low, PD-L1 all comers with chemo, EGFR, mutant lung cancer? Will it play a role in early stage? I think a lot of unanswered questions, but certainly an exciting chapter in the immunotherapy battle against lung cancer.